Um, okay, I'm recording now. Okay, so something that I wanted to get into, this is patho. So now we're thinking about how the disease is caused. And that's why I tried to further emphasize that a lot in med surg, because if you do understand the cause of the disease or how the disease process works, the symptoms and the management, I feel like all of that stuff comes together because they're related, right? So if something's causing ischemia or lack of perfusion, our goal is to get the body to be perfused again. So I feel like everything starts to relate and overlap with each other. And I just wanted to show you the heart wall. So your heart or the muscle of your heart has a few different layers. We have the epicardium, which is the outer layer, the myocardium, which is that inner muscular layer that really deals with the contractility of the heart. And then we have the endocardium, which is responsible for the valves. And the valves are really important for preventing backflow of blood to the heart and things like that. So, those are just some things that I want to put in your minds for right now, like thinking about the anatomy, because when I start talking about some of these, I think it's going to make more sense. And as I said, if you have Balkan, she's an anatomy love. She loves anatomy. So you are supposed to know anatomy anyway, but she loves anatomy. So it would be good to know it for yourself and to help you with understanding the disorders. So, like I said, we have the pericardium, which is that sac that lays outside of the heart. It's like a pillowcase over a pillow, and it cushions it and it protects it. That's what it is for the heart, and it helps prevent friction and things like that, and it keeps its position in the thorax or the chest area. There's different types of pericardial disorders. So we have pericardial effusion, which I said is that fluid buildup in the previous lecture in that pericardial cavity. We have cardiac tamponade, which is a result of pericardial effusion, which causes more compression of the heart because of that accumulation of the fluid or blood or whatever is in that sac. We also have pericarditis, which is an acute inflammatory process of the pericardium, or in other words, inflammation of the pericardium. It can be acute, chronic, or constrictive. And then we have constrictive pericarditis, which is, like I said, anything that ends in the itis is inflammation. So just know it's inflammation. And there's different times. And this one affects cardiac output and it could be fixed. So, like I said, anything that has to do with inflammation, it can cause things like edema or dyspnea because it's located so closely to the lungs that fluid buildup can be pressing on the lungs or your thoracic cavity and causing you to have problems breathing. So, I would say knowing the definition of it is really important. And I would say, like, understanding what acute versus chronic means would be important, but I can't see them going in so much depth with these. But acute pericarditis is based on the clinical manifestations, but acute means that it was caused by something, but it can go away. Chronic pericarditis is something that happens that causes this to be long term and it's not going to go away. So that's why it's very important to say, okay, I know the difference between acute and chronic because that could be something they easily ask you, like, what's the difference between the two, right? And yeah. So anything that I want to add is that different causes of pericarditis can include infections, tumors, and drugs. And something that you might get is sharp chest pain, which, as I said before, all of these are causing something to go on with the heart. That fluid buildup is pressing on the heart, which means there is a potential for ischemia. So there's chest pain, or the pressure of the fluid buildup on your chest wall can also cause chest pain. So that's an expectation. And this is inflammatory, which means you want to treat it using anti-inflammatories. Cardiac tamponade has to also do with this pericardium, and it's, like I said, a form of pericardial effusion, and there's compression of the heart now because of that continued accumulation of fluid. in the heart. So you could see in the difference between the two, where there's that black sort of figure around the heart, that's the fluid pressing on the heart and preventing it from doing what it needs to do. We have, as I said before, the coronary arteries and the coronary veins, whatever's going on there, those coronary arteries are really important to getting perfusion to the heart. That's why they're mentioning coronary circulation. Different types of ones. I really wouldn't say you need to know too much about this, but just knowing that these coronary arteries work to perfuse the heart. You have coronary heart disease, which means that there's impaired coronary blood flow that can cause angina. Why? Because of that lack of perfusion. Myocardial infarction. Why? Because that prolonged lack of perfusion leading to irreversible heart damage and a heart attack. Cardiac arrhythmias, cardiac defects, all because of that lack of blood supply. It can cause your heart to not work properly, which can include, like I said, arrhythmias, heart failure. As I said, it's usually caused by something. It's either congenital or heart failure is due to other comorbidities. And coronary heart disease is one of those leading causes, as you need those coronary arteries to perfuse the heart. And it can lead to sudden death. Now, I don't know if you really need to know stable versus unstable plaques. I've never heard of this, but stable plaques are supposedly with stable angina. And I guess that just means the plaque buildup that's there in that stable angina is going to still be able to be relieved by the rest and the nitroglycerin, and it's going to be caused by exertion. But unstable plaques are going to be associated with that MI, which is going to be causing, right, that buildup, maybe even a clot formation, which is completely blocking the blood flow, as you see right over here, right, because of that clot buildup, causing potential MI. Because remember, unstable angina, as we were talking about before, can lead to a myocardial infarction, and it can have ST elevation, but it's not relieved by anything. It's not relieved by giving that any sort of nitroglycerin, and it's not relieved by rest like stable is. So I think that's just the meaning of these. Like I said before, acute coronary syndrome can lead to an MI. So we want to watch, like I said, those cardiac markers like the troponin and things like that. Any sort of presenting characteristics like the chest pain radiating down to the arm, things like that. Timing of the presentation is really important. When did it happen? Why or how? Right? Because as I said, if the chest pain is caused because they hit themselves like 10 minutes ago and they're like, I have chest pain, and they banged their chest or something, or they fell, right? That might not mean they're having a heart attack, but we can't assume that. But like I said, it's good to assess the why. Or if they have a cut on their chest, that might be why they're having chest pain. Then we have classifications of coronary heart disease. So chronic versus acute, right? Acute ischemia, right? Maybe they have an MI, or maybe it could lead to that, right? But chronic stable angina this is more of like a slow process, right? So they might have it, but an MI might be waiting. It's just taking longer because they've had this angina or this ischemia for a long time, but it's not as bad because they've had it for so long. So yes, they're going to have that activity intolerance, but it's like when you have a chronic condition, you've had this. So the idea of having an MI right now today, maybe not so much, but acute means that something happened, maybe unstable angina or something that's causing this immediate, they might have a heart attack in the next hour. So that's where we're starting to see this idea of difference between acute and chronic. Things include, like I said, we're looking at those EKGs because we want to see, are they having ST elevation? The echocardiogram, right? We want to look more at their heart. Stress testing is another way of determining how the heart is able to pump. And I have no idea what a nuclear cardiovascular imaging is, but it just seems like it's another way to see what's going on with the heart. Any questions? No. Okay. So, unstable angina, not relieved by rest, not relieved by nitroglycerin, and it's not caused by anything, right? It's not the same thing like exercise or something that's doing. They just get this and nothing's relieving it. So NSTEMI means non-ST elevation myocardial infarction. So when they have this, this is not as severe as a STEMI. That is because of the fact that when they have a STEMI, that ST elevation is serious. That means it's immediate and we need to do interventions right away, or they could go into cardiac arrest. Um, but yeah, so NSTEMI is a non or a less severe form of STEMI and it's a part of that unstable angina. Like I said, there's really no evidence of this. You don't really know so much how this non-STEMI works, but um, if we see elevated cardiac markers such as troponin, that's letting us know they're going to have an MI. But they're not going to have any EKG changes. So that's a big difference. Um, so it could be from a plaque buildup. So if it's from a plaque, it might not cause that STEMI elevation if it's not like a conduction issue. Maybe obstruction, maybe severe narrowing of the coronary arteries, inflammation, or something that might cause, like I said, ischemia. All of these are pretty much caused by ischemia. Um, the next thing is characteristics of pain, right? So pain can be more persistent or severe depending on what's going on. So we're trying to see, is it occurring at rest? Is it not occurring at rest? Is it happening because of something? Is it lasting for a long period of time and it's not being helped by nitroglycerin? Then we know that we're going into this unstable angina. All of this stuff that I've been saying is pretty much being repeated here. Okay, so the next thing is, how do I diagnose? I wouldn't say you really need to know this for your exams, but I would know as a nurse because they can ask you things I need to look out for is the pain, hemodynamic stability, right? Like what's going on in their blood, what's going on with those lab values, those EKG, all of this can be, especially med surg questions. Um, we already talked about the different types of causes for angina, plaques or platelets, something causing some sort of ischemia or blockage, or secondary hemostasis, which is a blockage of blood flow that's caused by something, maybe a vessel ruptured or things like that. Okay. We already talked about the types of angina. We talked about stable, so I'm not going to get back into this, but as I said, stable is relieved with rest and nitroglycerin, and you feel it on exertion. ST elevation, as I said again, that's an indication of an MI, and that means that we have some sort of myocardial death to the tissue, and this is not looking very good. Okay. So once again, different changes. Something is causing that ischemia or that death to the cell tissue. Something is causing that, and it's irreversible. That's why immediate interventions are so important. That's why I said before we want to get that patient to the cath lab in 90 minutes to try to get an intervention in, because once they get to that cath lab, they are able to open the vessel and put a stent or a balloon or something to perfuse that heart. If they don't do that, we're in a serious issue right now. That's why interventions are so crucial because we don't want the damage to get worse. Um, and yeah, so like I said, myocardial infarction is caused by ischemia or death to the cell tissue. And we need to take interventions immediately because of this impending irreversible damage to the heart. Okay. Um, anyone who just joined, put your SFCID number into the chat, and I'm going to be posting the videos after. Okay, so yes, you could look at populations, right, that are affected. Those are all of those risk factors that we talked about in the lecture before with the med surg. It's the ideas of, right, are they having coronary artery disease? Do they have maybe untreated hypertension? Do they have hyperlipidemia, right? Is this an obese patient? Do they have some sort of coagulation or some problem with their clotting factors and they're clotting everywhere? Like, what's going on, right? Because as we know, and I keep emphasizing, a heart attack or a myocardial infarction is caused by myocardial ischemia or lack of blood flow to the heart. And it can be silently caused. Something's blocking that we don't know, like hyperlipidemia, cholesterol buildup in the plaques, and something's going on. So here's an example of the ST segment elevation that we were talking about before. It causes that pain. Like I said, pain radiates from the jaw to the left arm. And in cases where, like in women and elderly, sometimes they don't have those normal symptoms and they have things like nausea and vomiting. That would be an indirect symptom, but it is a symptom of a potential MI. They also have things like tachycardia, right? Because that increased heart rate because of the body not really being able to perfuse. That restlessness or anxiety, that feeling of doom because of that lack of perfusion to the body. And because of lack of perfusion, you have pale, cool, moist skin. That's why when I mentioned about peripheral arterial disease, they have a cool, pale skin. That's because they're not having perfusion because the arteries are being affected. So this is an example of an ST elevation on an EKG. And that might be good to know. They might show you that on a test. I've never seen it, but it's always fair game to know, especially what it looks like. Treatments for MI. Like I said, oxygen always first with those ABCs because we want to reperfuse and get that oxygen to the rest of the body. But we also can give nitroglycerin, not as like a pain management, but to help with the vasodilation or to help increase that so that the pain and as well as the ischemia can be reduced slightly. Morphine is more for the pain, but the nitroglycerin can definitely aid in that. As I said before, morphine has a property of actually helping the heart with the contractility, but we got to watch out for respiratory depression if you're giving morphine. And aspirin, because aspirin is an antiplatelet, and as we said, clots can be a cause of an MI. So they have a mnemonic called MONA, which would be good to memorize, but it's not in order of priority. Priority would be oxygen, nitroglycerin, then morphine, because oxygen is what we need. And if that's a test question, I would put oxygen. Okay, so therapies that you can give for MIs or things like that, like I said, these antiplatelets and anticoagulants, because of the fact that they are preventing clot formation. Platelets prevent that platelet plug, which prevents clots, or anticoagulants like heparin or warfarin, which prevent new clots from forming. They don't dissolve existing clots. So these are just some different drugs that we can use, okay? Now, as I said, something that they can do is do a CABG or a graft or whatever they're going to do. They're going to try to open the stent, and this thing is like a little balloon, and it helps go in between that plaque buildup and help perfuse or get perfusion to the heart and help with that MI or the ischemia. That's because our main goal is to reduce the heart's ability to pump harder because it's not having that perfusion of blood flow, and our goal is to reperfuse them. So that's why oxygen is our primary or priority intervention with these patients. Like I said, I don't know if you would need to know this, but endocardial infarct means that it's below the endocardium. And interestingly about that, if you have something that's below the endocardium, they're not going to have ST elevation. So sometimes you could see in, like I said, in an MI patient, ST elevation, but in subendocardial, you won't. That's just like I said, in that picture that I showed you in the beginning where you have the 3 layers of the heart, it's this infarction is occurring underneath the endocardium. Transmural means that it's happening all throughout the heart wall. And this one causes STEMI, and this one causes an ST elevation. That's really the difference between the two. I don't know if you'll be tested on it, but that's just the main difference. It's where it's located. So this one's underneath the endocardium, and the transmural is in the whole heart wall. I feel like this is all repeating everything that I said, so I'm not going to continue going into it. But like I said, looking at the occlusion, the heart tissue, right? How long has this been occluded? What is occluding it? How do we treat that occlusion to help with the perfusion, right? How much is the body being affected by this circulation issue? Looking at their heart rate, their blood pressure, and cardiac rhythms. I don't really know what this is. Post-infarction recovery zone. I don't know what this is, so I don't want to say I know. But I guess it's just areas in which different injuries can occur. So where each zone of occurs. Necrosis is one of the worst because necrosis means death. That tissue died. Ischemia means lack of blood flow, and then injury is just where the blood flow is starting to be impeded. And it's this outer layer that apparently I'm reading in here is where it's ischemic and it's the blood flow can start to be salvaged again. So that's where I'm seeing this. I don't really know anything about it, but I'm just reading it from the slides. Okay. So, another thing that we already talked about complications of MI. I feel like you're getting used to that, so I'm not going to spend too much time. Like I said, anything that occludes, anything that kind of causes this issue here, we really want to watch out for. Arrhythmias, pericarditis, all of this can affect the heart and cause an MI. And we already talked about troponin and creatinine kinase. And if you weren't here, these are really important biomarkers, basically lab values that tell you if you're going to have a heart attack or not. If they are both elevated, you're having an MI. That's what I would know about those. That could easily be a patho question. Which cardiac biomarkers do I look at? These are the two you want to look at. I don't know why this is blocked off, but we already talked about different ways that we can do that, how we could treat it. Angina, non-pharmacological, right? Like, how do we reduce stress on that heart from that ischemia without medications? Well, if they're smoking, is it plaque buildup? We want to reduce stress because stress can cause vasoconstriction and cause ischemia. Want them to exercise. We don't want them to have too much cholesterol because that can cause plaque buildup and that can cause ischemia. Weight reduction, right? Because the more you weigh, the more fat that you have, and that fat can cause plaques and further hurt your heart. And avoidance of the cold, especially if you're not wearing appropriate attire, because that cold is going to cause that vasoconstriction. And if you're in the cold for too long, you could have tissue damage. Any questions so far? No. Okay. So another thing that we have is myocarditis. It's another way of saying the heart wall where the contractility in the conduction system is inflamed. So that's what that means. Cardiomyopathy is let me just get I have notes on another thing. Okay. So cardiac myopathies are basically that there's a disease of the myocardial tissue and it's harder for it's harder for the heart to pump blood to the rest of the body. Primary always means that you don't know where it came from. Primary or essential anything means I don't know where the origin of this disease is. Secondary means something has caused a cardiomyopathy, right? So something is leading to some heart disease is causing this. So I'm not going to get too crazy into the different types because I'm going to get into it next. The main focused ones are the dilated, restricted, and hypertrophic. So I will get into them. But the definition of a cardiac myopathy is just a bunch of diseases that are associated with causing electrical dysfunction and inappropriate potential, the ventricles being hypertrophed or being expanding in size. And that can be due to different causes. And basically, there's something going on with the heart So we really have to be careful with that, because myopathy or pathy means disease, myopathy means, or myo means muscle. So there's something going on with the muscle of the heart. That's what cardiomyopathy means in medical lingo. Primary, secondary, I don't think they would really test you too much on this. I would just say read it over for your own knowledge. But I would know the definition of cardiomyopathy. So dilated cardiomyopathy just means that the heart wall is really big and stretched out. So you could see in this picture, right? Like the heart doesn't look so good. It's like really big. And that's because the heart wall is dilating and it's really not that good. Okay. And some causes are infection, alcoholism, idiopathic means you're not really too sure, or chemotherapeutic agents. But I would just remember dilated, my heart wall is big. Okay. Restrictive, opposite, too small. The ventricle of the heart is getting smaller, it's getting restricted. It's a rare disease caused by different things. It can cause dyspnea, orthopnea, peripheral edema, because, like I said, anything that constricts or restricts those ventricles can prevent backflow, and all of that backflow can go all the way as far as getting back into the rest of the body, which can cause that edema. And in the left ventricle, if it backs up, we get that buildup in the lungs, so you get lung issues or lung problems. Hypertrophic just means that the wall is really thick. So you see, this is normal blood flow, A, and B, we're seeing that that wall is just getting really thick, and it's making the entryway or the heart's ability to pump that blood into the aorta much harder because it's a smaller entry because the walls are bigger. That's what I would really know. I really wouldn't get too much into this. I have no idea what this is. I'm not saying that to mean I really don't know. I've never heard of it. I can't really see you being tested on it. So I would just say review it on your own. I've never seen it before. Even in my notes, I've been practicing for the NCLEX. I haven't seen it. Bringing back this diagram again, because the endocardium is something we're going to be talking about now, and we're going to be talking about endocarditis, which basically means that the bottom layer is being affected, which is really bad because the endocardium helps produce those valves. And valves are really important because valves prevent backflow, right? So it's kind of like a doorway, right? So it lets the blood in and then closes it. Lets the blood that it needs to in, it closes it. But if there's something wrong with them, now the doors might be semi-open and more people or less people are getting in than they are supposed to. So that's what's happening here. Endocarditis is damage to this endocardial surface. And basically, it's typically caused by some sort of infection. Something gets into your body and it's causing this inflammation of that tissue. And it can be caused by things like some type of bacteria, maybe an emboli. But there's two important terms which I'm going to repeat. If you're having infective endocarditis, right? Any sort of infection, all of these different types of fungi, bacteria, whatever. Risk factors, diabetes, alcohol, immunosuppression, right? Because immunosuppression, especially your diabetes, all of that puts yourself at risk for infections. And since these control the valves, that means that we might have stenosis, right? Which means that the valves become really narrowed, so blood can't really get through, or the valves might regurgitate and they might backflow blood back in. They kind of like spit it back out and it goes right back into the body instead of going up where it's supposed to. And remember, valves are part of the veins. Valves are not in arteries. So just keep in mind of that. Infective endocarditis, clinical manifestation. If we're talking about an infection, right, you expect things like, possibly like a fever and things like that, right? Anything that tells you that they have a potential infection, maybe a flushed face. Regardless, we're going to want to treat whatever it is. If it's a bacterial infection, we want to give antibiotics. If it's fungal, we want to give antifungals. And if it has something to do with the valves, then we want to have a valve replacement. And you could figure out if what it is if you do a culture and sensitivity, and you want to look at your blood cultures and see what's really going on in the blood. Rheumatic fever, I really wouldn't pay much attention to right now. It is a child's disease. Typically, you see this talked about. I would just know that it is caused by a streptococcal infection or a strep throat infection initially. I would just know that. I really would not get into that because this is more of a peds type thing that you'll take next semester. Functions and disorders of the heart valves. One of them, as we said, is the endocarditis. And it depends because remember, those valves help direct blood flow to the heart. So it could be congenital, could be due to trauma, ischemia, something is causing the valves to not work properly. And inflammation, as we saw with endocarditis, anything that ends in itis means inflammation. Any questions so far? No. Okay. So as I said, stenosis, if the valves stenose, that means that they're narrowing, so less blood flow is getting through, so the doorway is too closed, or they have regurgitation, so the blood flow is actually going backwards. So it's kind of like a swinging door. So the blood goes back in and then it closes. The blood goes back to the body and then the door closes again. So there's an issue with the valves when we have valvular disorders. Um, Once again, I would just know that mitral stenosis or mitral valve regurgitation means that valve is having the effect. And I actually put a picture because I love diagrams. So your mitral valve is in, like I said, it's a part of that anatomy. So I really think it's important to know your anatomy. It's a part of the blood flow that goes into from the left ventricle into from the left atrium to the left ventricle. That valve opens the blood. Opens so that the blood can get from the left to the left ventricle, so the left atrium to the left ventricle. The tricuspid valve is, or even the aortic valve, right? That's another. All of these valves control blood flow. So I just want to show you where they're located. So the two that we're talking about now is the mitral and the aortic. So the aortic is here. It's in that big red archway or that artery that we see over here, and the mitral. So if you're having mitral valve stenosis, you're having narrowing of that valve. If you're having mitral valve regurgitation, you're having backflow of blood at the mitral valve. Same thing, aortic valve, it's just where it's located. It's just another way of saying that. I hope that that makes sense. And yeah, so we have cardiac auscultation and echocardiography. Those are ways to see the turbulence of blood flow. It's a way for us to see what's going on. That echocardiogram is like a big x-ray of the heart, and you see the heart pumping, and you're able to see how the heart works to let us know are they having any of sort of these structural issues. And knowing your lung sounds and your heart sounds and all of that stuff is going to let me know, hey, what's going on with my heart? Am I hearing something or a sound that shouldn't really be there? Am I hearing an extra heart sound? Anything like that. Maladaptive and adaptive mechanisms, these are just different ways of your body coping, right? Sometimes the heart can't pump, or it pumps so much that the heart becomes hypertrophed. So the heart becomes enlarged, and that makes the heart work even harder, even though it's a compensatory mechanism. Or you have your sympathetic nervous system kicking in and saying, hey, let me increase the heart rate. Let me increase the blood pressure to try to help perfusion to get to the body. But sometimes they might not always be good. So these are just different ways of the body naturally trying to reduce or fix issues when we have heart failure. And as I mentioned before, heart failure is the heart not being able to do its job, and its job is to pump blood to the body. So I would really know this. As I said, Balkan does like anatomy. I'm not sure about Kessler, but I would think both teachers would find anatomy or how blood runs through the heart really important, starting with the superior and inferior vena cava and then going through. I would know that because I can see that being a test question. It's fair game since we're talking about how all of these disorders affect the heart and circulation to the body. But how do you really know that if you don't know the anatomy? So heart failure can cause a high output where it could be so much, it's really trying to compensate by really sending out the blood. It could have a low output, meaning it's not really able to pump it out. So we're getting that vasoconstriction, that paleness, because it's not enough blood flow, and they might get those cyanosis, those blue fingernails, toes, lips. Um, Different things can be causes. Systolic dysfunction, which means the top number, or the systole, the ventricle's ability to pump is not working, or diastolic, which means that the heart's ability to rest in between the contractions is not really efficient. So impaired filling, right? The relaxation causes the blood to fill or go into the ventricle so that during systole, they can pump the blood right back into the body. Just these are different ways that heart failure can occur. We already talked about the symptoms, but I'm going to go over it one more time because heart failure is so important. So, this is not my handwriting. This was in your slides. Left-sided means lungs. It backs up into the lungs. So every symptom you are expecting to see is going to deal with lungs. So dyspnea, tachypnea, crackles, right? Crackles is from that fluid buildup from the blood flow backing up into the lungs. You might have something called paroxysmal nocturnal dyspnea, which means you're having trouble breathing at night. And as I said, you might also have oliguria, which is decreased urine output of less than 30 ml per hour, because the left side of the heart's function is for the left ventricle to pump that blood into the body, and the kidneys take about 25% of your blood flow. So what happens here is that the kidneys are not getting perfused, and now you're having low urine output. But if you can't remember it, left-sided lungs, I'm expecting lung issues, decrease O2 stat, things like that. Right-sided, looking back at that anatomy, is going to go back into the body, right? So when it goes back into the body, you're going to have edema. You're going to have JV distension, which is a vein in your neck. You're going to have abdominal distension. You're going to have spleen and liver enlargement. That's what hepatomegaly and splenomegaly stand for, which is why, because when the blood flow backs up, the liver and the spleen are right there. So that fluid starts going into the spleen and the liver and causing them to swell. They might have weight gain. Why? Because the fluid is building up and going back into their body. That is why it's so, so important to do daily weights with our heart failure patients. And they might have anorexia because they might not be able to eat as much or tolerate as much. And yeah, so this is just a little summary of how things get turned around. And this is like a little chart that kind of explains all the symptoms. Might be good to further emphasize or better understand how the system works. But like I said, if you understand where they back up based on that anatomy, then you understand why left-sided backs up into the lungs versus why right-sided backs up into the body and the symptoms that it causes. Any questions? No. Okay. So there's a lot of things that I'm seeing with pediatrics here. I don't really know personally how much you might get tested on it. Um, but long story short, when a baby is in the mother's womb, right? It takes almost until if I think it's like 20 something weeks until their lungs are like really, really developed, right? And they have gas exchange and things like that. That's why it's scary when premature babies are born, because they might not have that lung alveoli or that gas exchange ready, and that heart is not going to be able to get perfused properly. So there's things that might happen after they're born or during that whole process in the mother's womb of them developing that can cause them to have issues. And these are just examples that can affect the pulmonary vascular development because those lungs and those heart work together. That's why we have the lung issues when the heart fails to pump. They also can have heart failure and pulmonary vascular diseases and things like that. And you'll learn in your peds and other classes that they have a different structure of the heart. Their heart as a baby and when they're in the womb is much different than our heart in terms of structure and how the blood flows. I would definitely know chronic versus acute, right? Chronic is long-term heart failure, and acute is more of that short term, something happened. Maybe, like I said, they had an MI and that caused fluid buildup, and then the heart temporarily couldn't pump. Different things can cause it, so you want to be mindful of that. And chronic means they had it for a long term and they have decreased cardiac function over time. So, the terms of who you want to treat first, you're going to want to go to your acute heart failure patient versus your chronic. Like I said, fetal blood flow is a little different. I don't really see this being on your exam, but basically, though just the way the heart works, it just works very differently. It has different openings for blood to get to the body. And the left ventricle does primarily take blood to the upper parts of the body, but the right ventricle, most of it goes to the placenta and things like that. But like I said, I don't want to get too into it. Just know that they have a different system or mechanism for the blood to flow in the body, and they have these different openings. Like a foramen ovale and a ductus arteriosus, they're different openings for blood flow to get to different parts of the body because they don't have the structures that we do. Cyanosis and shunting, I think it's really important to know that, cyanosis is decreased peripheral perfusion, so it's causing that blueness or that shadiness in the skin. And in children, right, crying or defecating or like they're having trouble feeding would definitely be a sign of children experiencing some sort of arterial lack of perfusion. And shunting is basically like I forgot kind of how to explain it, but you might have to search that one up. But with shunting, I just know that it affects how the blood, so it like skips. So it goes from right to left and it skips the lungs, I think, something like that. It does something where it skips a part. So it goes from left to right and it skips the lungs. I think that's what it does. I'm not 100% sure. So I would just say look into that. But yeah, there's different cardiac heart defects. I really wouldn't get much into it. I would just know maybe Kawasaki's disease. You never ever give aspirin to children, but if you do, it's in this disease. And they get like a redness on the hands and the feet, which is a very, very common symptom of this disorder. So I would just know that. I really wouldn't get much into it other like with all these children disease other than Kawasaki's and looking into this. And it's caused by an immune problem. It causes the vascular beds or the vessels to inflame, and it's not good. That's why we have fevers and rashes and redness on the hands and feet and things like that. Mainly heart failure is usually congenital. That's the main thing with children. I would know the aging process. I think you could be tested on that. Just know as you age, your vessels become stiffer, okay? And the heart, especially the left ventricle that pumps to the body, might get hypertrophed or the wall might get bigger, so that's not good. You also have reduce responsiveness to those beta receptors that we have in our lungs and in our heart. So the heart's capacity, not as great. And heart compliance, or the heart's ability to pump, all of that decreases. And yeah, is there any questions before I get into shock briefly? No? Okay. So like I said, heart failure, I would just know it's mainly congenital. I would really not look much into this for right now. Maybe just read it over. So for shock means that your body and your vital organs are not getting adequately oxygenated, right? You're not getting perfused. But aren't all of these orders doing that, right? All of these disorders are causing some sort of lack of perfusion to the rest of the body. So the organs aren't being able to be adequately oxygenized, right? And it can happen in three different ways. It can be caused by an issue in the blood, it can be caused by an issue in the vessels, or it could be an issue in the heart, okay? So those are the three components that may or may not cause shock. Depends. So cardiogenic shock means there's something wrong with the heart. There's something wrong with the heart's ability to pump blood. Okay, so it's the failure, or the heart is failing to pump, and all of your blood and all of your vital organs are not being able to be perfused. Some causes include MI, right? Because of that lack of perfusion, cardiac tamponade, or pulmonary embolism. Those are causing obstructions of blood flow, or heart failure, because as we've seen in heart failure, it's the heart can't pump properly. Manifestations include decreased blood pressure and increased heart rate. That's because the body's not being perfused properly, so there's not enough volume in the body circulating. So there's going to be a decrease in blood pressure, and as a compensatory mechanism, you're going to have an increased heart rate. Always have those O2 requirements, so we need to give them oxygen because they're not being able to be perfused properly. And because of that lack of perfusion, because of that lack of oxygenation, their cognition or their mental status is going to change. So, nursing interventions, monitor blood pressure, look out for the heart rate, give them O2, and monitor their mental status. Treatments, improving the cardio output and reducing the workload of the heart by doing the interventions we talked about. Hypovolemic shock has to do with volume, right? There is something wrong with volume. There's a blood loss or a volume loss of some sort. That includes bleeding, dehydration, okay? Burns, something that's reducing fluid, okay? So what we want to do to treat it is improve the volume to help promote perfusion. Same sorts of symptoms, that tachycardia, that decreased blood pressure, that cool, clammy skin, decreased urine output, all of that. You also would have that in cardiogenic shock because it's the lack of perfusion to organs, and especially those kidneys are affected. And cognitive changes, as I said, that lack of perfusion to the brain. Treatment, if it's bleeding, let's give them blood. If it's dehydration, or they're vomiting or having diarrhea, let's fix that and let's give them fluids. Let's give them electrolytes, right? If it's from burns, we want to give them fluids. We want to treat whatever is causing the hypovolemic or the low fluid volume. Obstructive shock are caused by things like the cardiac tamponade, or pulmonary embolism, because remember, cardiac tamponade is that fluid buildup. It gets so bad that it starts to compress the heart, or a pulmonary embolism, which is a clot that forms in the blood vessels, causing an obstruction of blood flow. So that's how we see the difference in between like obstructive and others. But obstructive shock is a type of cardiogenic shock. So other things are septic shock, which I think is really important to know, because septic shock is caused by some sort of infection, right? So bacteria gets into the blood and it gets through systemically, and it's causing vasodilation. That's why it's called distributive shock, because instead of being in these places like the heart, there's a certain cause, this gets everywhere. This is causing systemic vasodilation, which is causing decreased blood pressure and all of that stuff. So with septic shock, we want to give antibiotics. That's how we want to treat it, because this is caused by a bacterial infection. Other types of shock, if I know any, you should know anaphylactic, right? It's that swelling, it's an allergic reaction, and we want to give them that EpiPen, right? They might have dyspnea and things like that. I would look into that. That one is really important, but knowing to give epinephrine during an anaphylactic shock, really important. Now, I would just know these, I wouldn't get into them much, but complications, right? If shock is causing lack of perfusion to organs, vital organs, we're talking about lung injury, right? Think about the anatomy of the heart. The lungs are not going to be able to be perfused properly if there's not enough perfusion getting to the lungs. The kidneys are going to be affected because the kidneys aren't being perfused. You're going to have GI ulceration because sometimes what your body does is they might say, hey, you know what? My bowels don't need much blood right now, so I'm going to reduce even more blood flow to that area and put it somewhere else. And that's going to cause ulceration buildup. We also might have disseminated intravascular coagulation, which is in a fancy way of saying a bunch of clots all over the body. Okay, as a result of the heart's ability not being able to do what it needs to do. We also could have multiple organ system dysfunction or all of your organs just shutting down. Like I said, I think you could just read into all of these problems. I don't think you necessarily need me to like go into them, but just disseminated intravascular coagulation, like I said, widespread formation of clots. They can ask you that. Multiple organ dysfunction, complication of shock because of prolonged shock, prolonged lack of perfusion to the body, everything shuts down. Not good. And treatments to correct it, like I said, whatever it is it a blood? Are they bleeding out? Is that why they're having shock? Let's get them blood, right? Always we want to give them that oxygenation. Is it they're having dehydration? Is it a burn? Are we giving them fluids? What are we doing? We're treating whatever it is. If it's septic shock due to a bacterial infection, we definitely want to get them those IV antibiotics. Okay, so I went through all of your slides. Now, is there any questions?